Welcome to Prime Oncology's Clinical Updates in Cancer from the 2015 ASCO meeting. My name is Dr. Nasser Hanna from Indiana University, and I'm joined by Dr. Mark Socinski from the University of Pittsburgh. We're going to be discussing the major abstracts in the lung cancer sessions from this year's meeting. Mark, welcome.
Thanks.
So, of all the abstracts that you heard, all the studies that we heard this year, what is, in your opinion, the top most practice-changing study we heard?
I think, undoubtedly, in my opinion, it's the two CheckMate trials that explored nivolumab in the second-line setting versus a standard that we've held in our hand for 15 years, single-agent docetaxel. Nivolumab, an anti-PD-1 agent. We've been hearing about this drug for several years in phase 1 and phase 2 trials. Obviously, the take-home message from those is that it's well tolerated, it has activity, it has this striking ability to induce very durable responses, and responses that last even after the drug is discontinued. But we didn't have phase 3 data. We had hints of phase 3 data because nivolumab was approved in March. But we didn't have a chance to see the data. So at this meeting, we saw both the CheckMate trials that compared, they were similar design, compared in the second-line setting, so one prior platinum regimen in both squamous and non-squamous, nivolumab to docetaxel. Both of these trials were positive in the intent-to-treat analysis for overall survival, which was the primary endpoint. And the hazard ratios, in the squamous was quite impressive with a hazard ratio of 0.59 relative to docetaxel, a 3-month difference in median survival. And the hazard ratio for the non-squamous was 0.73, and again, met its primary endpoint. We've had nivolumab approved in squamous since March. And I think, I'm hoping and I'm assuming that because the non-squamous trial met its endpoint of overall survival, that we'll have that same drug available for non-squamous in the relatively near future.
Yeah, when I look at the data, I agree. It's very compelling data. It's absolutely practice-changing, in my view, in both the second-line setting for both squamous cell and non-squamous cell. I actually thought the curves looked even more impressive in the squamous cell comparison versus the non-squamous.
Yeah.
It seemed as if the survival curves split very early in the squamous population. In the non-squamous population, they sort of overlapped for a while, and then they split.
It was a late effect, more of a late effect than the non-squamous, where the squamous, you're right out of the gate, these curves separate.
And so one of the things that has been talked about a lot at this meeting and other meetings is, can we select patients for these therapies? Is there something different, and maybe these are really no different, but what are some of the thoughts about why maybe the squamous cell patients may respond even better, and why lung cancer in general seems to be so susceptible to this type of therapy?
Yeah, it's interesting when we initially had, the last big wave of drugs, the EGFR tyrosine kinase inhibitors, there was a kind of a clinical profile, the never smoking female with adeno responded better. Of course, we figured out why that was the case. But with regard to the PD-1 and PD-L1 agents, there doesn't seem to be a clinical phenotype that suggests higher response rates, with one exception, and that's been the smoking history. And, we know that squams are more tightly linked to smoking history, adenos less so. So maybe that explains the difference. And, one of the controversial things, I think, from these two trials is what's the role of the biomarker? Now, we know nivolumab initially approved in the absence of a biomarker, so there is no molecular or immunohistochemical selection for that drug. But, I'm kind of a believer that not every drug works in every patient. It's clear that not every patient benefits from nivolumab. So I think we have some work to do with regard to the biomarker issue. One of the more interesting things that's coming out of this work is this term that we're a new term in our world, and that's mutational load. And then the more mutations you have, the more these drugs seem to have activity. And so that's an interesting, and that may explain why it looked a little better in the squamous. And in the squamous, the biomarker, at least my interpretation of the biomarker, is that In the squamous subset, the biomarker really didn't make a difference. There was some discussion in the non-squamous that if you were biomarker negative, that there was really no clear advantage of nivolumab over docetaxel. This was an exploratory analysis, so I think we have to figure that out in the future. It really doesn't affect my personal practice right now. I'm not going to ask my pathologist to start doing PD-L1 assays because that's a whole nother issue in terms of the issues around the biomarker, but it is interesting that we'll have this to sort out over the next several years.
Yeah, and Dr. Spiegel's presentation for the non-squamous, non-small cell, he broke it out into those that had PD-L1 expression in 1%, greater than 1%, greater than 5%, and escalating from there. What I thought was interesting is, there was a suggestion that the more PD-L1 expression, maybe the more benefit, but even in the group that was did not have PD-L1 expression, while nivolumab was not any better than docetaxel, it wasn't any worse either.
Right, exactly.
And it does have, in my view, a better safety profile.
Yeah, I was just going to say, even if the drug is not better, but it's equivalent, at least from this trial, I think it does have a favorable toxicity relative to docetaxel. And so I would favor that. And as well as I know, patients are now coming in asking about immunotherapies and thinking that it's the next wave of patient-derived enthusiasm about getting treated for cancer. They like the idea of an immunotherapeutic agent.
Yeah, and I do too. And I think it's definitely practice-changing. It's paradigm-shifting, all the words that we like to use in oncology.
The one comment I'll make is that it's a different spectrum of toxicity for oncologists. So we have to be aware of the spectrum of immune-related adverse events. These are different than what we are typically seeing in this setting with agents like docetaxel or erlotinib, which have been the standard of care for years in the squamous, and pemetrexed in the second line setting. So I think some education from the oncologist, from the oncology nurse, and these sorts of things, and in the patient to pay attention to certain early symptoms where you need to intervene to manage the toxicities.
Yeah, I think that's a great point. The docs that take care of a lot of patients with melanoma and with renal cancer, they're used to working with immunotherapies. I recently had a patient who had nephritis, and it was an educational experience for me because not only do you have to treat them with the steroids, but you have to prolong the steroids for a little while. You can't just treat and say, okay, things are better after 2 or 3 days and stop. If you don't taper them over a few weeks' time, they can rebound in even worse condition.
Yeah, I had a gentleman recently who developed colitis. And of course, he was admitted to an outside hospital, and kind of over the weekend. So we didn't quite know about all of this, but he came in to see us and follow up. He was better. His colitis, his diarrhea had resolved a bit. He had been actually colonoscoped and biopsied at the outside hospital. Had he been in our hospital, I probably would have intervened with the high-dose steroids because he was having grade 3 toxicity. But this is an education that goes beyond oncologists. This is a new era of immunotherapies that I think all of our supporting docs need to know about too. So it is a new paradigm.
One of the other interesting things that I find about immunotherapy that for me distinguishes it from the cytotoxics is the durability of responses. And the median duration of response is 3 to 4-fold with what we see in chemotherapy. And in the melanoma world, 20% of people maintain responses for 5 years. Now, I don't think we're going to necessarily see that, but we are seeing, and in my personal practice, I am seeing some patients who have nice, durable responses, and that was one of the more compelling things out of this data.
Yeah, I completely agree, and it brings up the issue of duration of therapy. None of these drugs are cheap. If you can induce and engage the immune system to control the cancer, can you stop therapy? And there's lots of examples. Scott Gettinger's paper recently in the JCO, I think, was very illustrative of the fact that you do see these durable responses. They last a very long time, and they last even if you stop therapy. And he has a very nice figure there where he had a patient on NIVO for 2 years and then off NIVO for 2 years. still in a response with no therapy. So, the immune system must not forget, right? Once you can engage the effector cells to have an anti-tumor response, they're primed and they'll control the cancer. So, a very different paradigm than what we grew up with in our training, historically. So it's a very exciting time.
And not only do the immune cells not forget, they also adapt.
Yes.
So when the environment changes,
Yeah.
In our world, the cytotoxics can adjust to the changing environment, but the T cells can.
Yeah, absolutely.
And I think that plays a role.
Yeah.
So you brought up mutational load. It's fascinating to me that we're seeing responses in tumor types that have historically not had much activity. In this meeting, we saw abstracts with the immunotherapy in small cell lung cancer.
Yeah.
Do you want to share your thoughts on that?
Well, yeah. So I think that it is in many ways refreshing to me that we have spent several years, in enriched populations of never smokers, finding first EGFR mutations, then ALK, and then ROS, and then this meeting we saw the RET presentation. Almost all never smokers in that presentation, and now the data that we've seen with immunotherapies in those populations is really not that impressive. Mm-hmm. We had a nice abstract presented yesterday about the low expression of these immunomarkers in EGFR mutants and ALK translocated patients. So those tumors, I guess, are not as inflamed as the other tumors. So this is kind of refreshing that we have an option for the majority of the patients that we see. We still know that 80% or so of the patients that we see in our practice have a smoking history. And some obviously is quite extensive in many patients. And so this, mutational load that really creates a lot of neoepitopes in immunogenic phenotype, if you will, that the immune system, once engaged, can recognize, I think is a great advance. As much as we have loved the EGFR TKI story and the ALK story, the majority of the patients on our clinic list are not EGFR and ALK patients. They're the kind of the typical squam and non-squams that don't have an actionable genotype, and this is a great option for these patients. The question is, will that evolve into a biomarker that we can use in the clinic to help us with who gets greater benefit? And my personal feeling is that the biomarker matters a lot, not in second, third, fourth line, because the data suggests, and I don't know how you feel about this, but I'm not sure there's a patient I wouldn't give a trial of NIVO to at this point, or Pembro on a clinical trial or whatever. But in the first line setting, again, I'm convinced that there are patients in the first line setting that are going to get substantial benefit, much more benefit than, say, carbotaxol or carbopem. The question is, how do we find those patients? And I think that's where the biomarker comes in as a really important aspect of this. We have several first line trials ongoing. Most of them are biomarker enriched when you're looking at monotherapy from the immunotherapeutic point of view. So I think that these are trials of great interest. One is completed accrual with nivolumab. Others are ongoing. So I think that over the next couple of years at this meeting, we'll probably start to see some first-line data emerge, because I'd like to induce an immune response right out of the gate and have that patient have a durable response. We don't tend to see durable responses with chemotherapy, but this would be a real advance.
And it's been exciting to have these advances in patients who make up the majority of our patients that, are usually heavy smokers, and they oftentimes have highly mutated tumors. And small cell lung cancer is an example in which we've really made, you could argue, very little progress in 20 years,
if
maybe
any.
Even, if any. Yeah. Maybe in limited stage disease, I think we've made a bit with radiation techniques. Yeah. But we heard at this year's meeting that PD-1 inhibition, there was an abstract with Pembrolizumab that induced several responses. I think the PR rate in a small sample size was about 25%. And combining PD-1 with CTLA-4 inhibition also results in about, I think it was about a 35% response rate when they updated their data. Yeah. That's extraordinary for these patients.
Absolutely. As you know, and this was in second line or previously treated small cell patients, where our options are very limited in I'm still, you struggle week to week to convince yourself that you're really providing clinical benefit in this setting with what we currently have for our therapeutic options. Yes, Scott Antonio presented that data. I was very impressed with that data, as well as Patrick Ott's data in refractory small cell, that there was a glimpse that these drugs may have activity. It kind of makes sense because of the most tightly linked to smoking is small cell, and so it kind of follows the mutational load. The one of the abstracts presented took all comers, and then one took PD-1 positive patients, and that really limited or excluded the majority of patients. So hopefully moving forward, we'll kind of be agnostic to the biomarker and get some data on what it means in small cell and how it may guide therapy in that setting. But I completely agree with you. This is a very refractory clinical setting that frustrates us all because we don't have good therapeutic options. And if this story continues to unfold like we heard the other day, then I think that's another area that would be very much benefited.
Well, another area that I found interesting and sort of frustrating was the data comparing Afatinib versus erlotinib as second-line therapy in patients with squamous cell cancer. Yeah. And one of ASCO's sort of mandates a few years ago on the top 5 things not to do, one of them is not to give a targeted therapy unless you have a patient that has a molecular target for that therapy. And so in squamous cell cancer, we don't really see EGFR mutations all that often. So what are your thoughts? Now we have for squamous cell cancer, we have, of course, nivolumab as approved in the second-line setting. We have docetaxel, which is still an approved drug. We have docetaxel plus ramucirumab, a study that wasn't really even talked about much in the comparison of these trials. And we have erlotinib, which is FDA approved in the second and third line setting, even for squamous cell. So we saw the largest phase 3 study ever done in second line squamous cell comparing Afatinib versus erlotinib. What did you think about that? Tell us about the results and where does that fit in your treatment plan?
Well, yeah. So getting back to your point about, I completely agree with you. You have to have a target, but I guess it depends on what you define as a target. Squamous cell is, if you use IHC and look at protein expression as your target, it's there in squamous cell, and that was part of the rationale for doing this trial. Erlotinib has been an approved standard for squamous cell based, since BR21, and is an FDA approved option. Afatinib's a different drug, second generation drug, pan-HER inhibitor, so it gets HER2 and HER4. It's irreversible relative to the reversibility of erlotinib, so it is a different drug. And LUX-Lung 8 compared it in squamous cell, as you say, the largest trial, to erlotinib, and the primary endpoint was PFS. And we heard, I think at ESMO or a previous meeting, that it met its primary endpoint of progression-free survival
by about 1.5 weeks or something like that.
Yeah, close. It'll be like the Belmont this weekend, hopefully. But the surprising thing was the secondary endpoint of overall survival. Now, I had not seen the actual survival curves until the presentation. And, I must say, this is a case, too, where there was some early separation, consistent separation, a hazard ratio of 0.81, which in the past, that's the hazard ratio we accepted for adding bevacizumab to Carbotax. So, in my mind, if you're kind of close to 0.8, I pay attention to. The further north of 0.8 you go, the less I pay attention. The further south you go, the more enthusiastic we are. So this was kind of in the range where, we have this drug out there. Of course, it's indicated only for EGFR mutant patients at this point. But this seems to be a better EGFR TKI in this setting because it benefits in terms of PFS. The response rates were low for both, but disease control rate was better, and overall survival was better. So the striking thing to me is, in a matter of 6 months, in the second-line space for squamous, we've had NIVO, ramucirumab added to docetaxel, and now this Afatinib data. So it's after more than a decade of stagnant, therapies.
Yeah.
All of a sudden we have like, how are we going to do this now in the second line, and what should take priority, and so on and so forth. So there's a lot to digest with these sorts of things.
It's a really great time to be an oncologist and to be in oncology research, and I think this has really recharged our batteries.
Yeah,
and
I mean, you and I remember the days where we would argue, is Carbotax better than Sysgem?
What's the best dose of Taxol?
Right,
Should we give it weekly?
Right.
So yeah, but these are far more important and more promising things for our patients, because now when I enter patients onto clinical trials, I was always enthusiastic about it before, but there's really a hope there that we've seen it in our practices, patients who are really responding extraordinarily well, and I have a lot of enthusiasm.
Absolutely,
so it's good times.
Absolutely, yeah.
Yep. Well, I think we should probably wrap things up at this point. I'd like to thank Dr. Mark Socinski, and I'd like to thank you for tuning in. And that's really, I think those are the highlights from lung cancer in 2015 ASCO. Thank you very much.